Hi, good afternoon, everyone. Thank you so much for joining us for our third and final webinar in the Bridging Ryan White Providers and FQHCs series. My name is Andrea Weddle, and I am the Executive Director of the HIV Medicine Association, and HIVMA is sponsoring this series as part of our initiative to develop tools to help HIV and Ryan White providers adapt to healthcare reform. The project is supported with generous grants from Janssen Pharmaceuticals and the MacAIDS Fund, and we really want to thank them for their support. Today's webinar will address opportunities for Ryan White providers and FQHCs to enter into collaborative agreements or business partnerships. The first webinar provided an overview, if you missed it, of the 19+ requirements for becoming an FQHC, and then the second really dove into providing information on the pathways to becoming an FQHC. Both of these webinars are archived on hivhealthreform.org and hivclinician.org, along with some additional reading recommendations for anyone who wants to have some additional background information. A couple of housekeeping notes before we get started. We are again recording this webinar, and it will also be available on the two websites that I referenced. All of the participant lines have been muted, but we really want to hear from you, so please submit your comments and questions using the question box anytime during the webinar, and we will get to as many as possible during the Q&A period at the end, and we'll follow up with those if we're unable to get to your question. So now I'm really pleased to turn it over to our experts today from Feldsman+Tucker+Leifer+Fidell, who I feel really lucky that we were able to partner with them on this series. They've really shared a wealth of experience on this issue. Feldsman+Tucker+Leifer+Fidell is a firm that specializes in federal grants, health, and family law, and also serves as the legal counsel to the National Association of Community Health Centers. So today we'll be hearing first from an associate at the firm, Emily Pinkham, and then she will be followed by a partner at the firm, Carrie Riley. So now I'm going to turn it over to Emily.
Great, thanks, Andrea. And welcome, everyone. Thank you for joining us today for the final webinar in this three-part series. We've enjoyed hosting it and working on it. So this afternoon, we're going to discuss collaborative opportunities between Ryan White grantees and health centers. And as Andrea mentioned, not the subrecipient relationship or becoming an actual FQHC that we discussed last time. So we'll get right along moving to our agenda. I'm going to start out with a quick review of the benefits of Ryan White FQHC partnerships. And next, we're going to go through what we're calling the spectrum of integration, which describes the range of different ways that Ryan White grantees can partner with health centers. And as I mentioned, we're not going to discuss the subrecipient relationships today since we covered them previously. But if you missed it last time, please take a look in the archives of the second webinar. It was called Pathways to Becoming an FQHC. And if you still have questions about this model, feel free to ask them during the webinar today. So finally, we'll address the practical concerns of how to go about setting up such a relationship by discussing some next steps and suggestions for initiating a partnership with a health center. So let's get started on the next slide. Why collaborate in the first place? What are the advantages of partnering with a health center? I'm going to start with a brief review of the potential benefits, and please bear with me as there may be a little bit of repetition if you've joined us for the previous two webinars. So next slide. As we mentioned before, health centers get a number of unique benefits in recognition of the increased costs that they bear in caring for medically underserved populations and the broad spectrum of support and enabling services that are often not covered by public or private insurance. So this slide describes benefits that are available to both grantees and lookalikes. First is fair payment. Under Medicare and Medicaid, health centers receive payment via prospective payment system methodology, also known as PPS. And Medicare payments are based on a national rate, adjusted based on location, but there is some variation in Medicaid since some states choose to use an alternative payment methodology that's been approved by CMS. Next is the federal 340B drug discount program, where drug manufacturers provide outpatient drugs to certain covered entities, such as health centers and Ryan White providers at discounted prices. Next is FTCA. We talked a little bit about the Federal Tort Claims Act previously, but it's a really significant benefit for health centers. And there are two key points to keep in mind here under the FTCA. This coverage makes it so that deemed health centers do not need to purchase separate malpractice insurance, which is a huge savings, of course. And second, if someone were to file a claim against a health center, the Department of Justice actually steps in to defend them. So the health center doesn't have to bear the cost of defending themselves in a lawsuit, and there's an entirely separate judgment fund that covers these costs. Now, another core health center benefit is the safe harbor under the federal anti-kickback statute. And just as a quick refresher, the anti-kickback statute prohibits the inducement or receipt of anything of value in exchange for patient referrals. So in other words, it's intended to prohibit arrangements that promote the unnecessary and costly provision of healthcare services. Now, the safe harbor protects health centers and their partners when a partner provider gives a health center what would otherwise be a donation or a gift. So for example, a lease for below fair market value or a grant of specific amount of funds that is intended to defray the cost of care. So the safe harbor kicks in when this, what would otherwise be a donation or a gift, benefits the medically underserved population served by the health center. For example, by increasing the availability of services or the quality of services they provide. And this does not extend to situations where the health center is the donor. It's only when the other provider or provider organization that is partnering with the health center is providing the donation. So keep in mind that if a gift or donation doesn't fit squarely within the safe harbor, that doesn't mean that it's automatically a violation of the kickback statute or that you can't have that type of relationship without violating the kickback statute. We just wanted to highlight this today because it's a common concern of provider organizations who want to work with health centers and provide some type of gift or donation, whether it be services or space or equipment, that they're concerned could violate the kickback laws. So we'll move on to the next slide. A couple other benefits to mention. Health centers have access to providers through the National Health Service Corps, and they also have access to the Federal Vaccines for Children program, which provides vaccines at no cost to children who might not otherwise be vaccinated due to lack of insurance or an inability to pay. So now that I've gone through the benefits, here's the all-important legal disclaimer. An individual provider or provider organization that's collaborating with a health center does not get these benefits by virtue of working with a health center. Instead, the benefits rest with the health center and they attach to certain types of arrangements or to the patients seen under a certain type of arrangement and thus the provider seeing them. So when I say attach, I mean that how a collaboration is structured impacts if and how these unique health center benefits will apply to that relationship. Now, I don't say this to disappoint all of you, but it's important to note that these benefits will not extend to the partners themselves. But as I mentioned, they can benefit the arrangement, and we'll be giving some examples of this as we go through the rest of the presentation. So next slide, what are the advantages? If you can't get the benefits, if there's a particular gap in services that a Ryan White grantee has identified, then the best collaborative partner clinically, operationally, financially might be a health center because they can bill under an FQHC rate, and to the extent that the health center staff are furnishing the services, they may be covered by FTCA if the health center is deemed. Of course, even without the health center benefits, there are still advantages to collaborating. While the motivating factors will vary, still on the slide, thanks. So the factors will vary based on your needs and expectations, particular circumstances, but there are distinct clinical advantages that come along with any collaboration. As you all know very well, there's mounting evidence showing the value of clinical integration in healthcare delivery in general. Partnerships with other provider organizations allow each organization to improve access for patients to a broader scope of services than each provider could offer independently. And access is not limited to services. Collaborations can also expand access geographically. This is done, of course, by operating new locations or co-locating providers in order to facilitate appropriate care delivery. And this can often increase the patient populations of both parties. We've also seen how better care coordination can improve health outcomes and care management, particularly in the reduction of inappropriate use of ERs, but it can also help organizations to recruit and retain clinical staff. So in all this, remember that health centers are specifically permitted and encouraged to work with other local providers to furnish required in additional services that they can't provide directly, and just to collaborate in general, however they see fit. Let's move on to the next slide. Of course, there are financial advantages to collaborating with other providers as well. So the primary advantage is, of course, the reduction of unnecessary duplication of services, which maximizes the resources of both parties. And commonly, organizations look to a reduction of administrative costs that can be achieved by integrating or sharing certain functions. This can also increase sources of and access to capital and financial support. To the extent that an arrangement creates a more prominent presence in the community and care coordination helps the organizations reach a broader audience, there's a likelihood that you're going to serve more people. And depending on the payer mix, there may be opportunities to increase revenue by virtue of the increase in patient visits. And finally, working together allows both parties to optimize their existing federal grant dollars. And to the extent that there are other relevant funding opportunities from states and private funders, or even federal dollars through demonstration or SPINS projects related to innovative models of integrated care, partnering together may actually create an advantageous framework for applying for future opportunities. All right, next slide. We're going to do a quick poll just to get an idea of who's listening in today. So the first question is there an FQHC in your community? We'll just give you a few minutes and an overwhelming response. It looks like we've got well over 90% saying that you do have an FQHC in your community, and only a handful of folks who do not. So for those that answered yes, which is most of you, we have a follow-up question. What would you say, would you say that you have a close working relationship with the FQHC in your community? And it looks like we've got a slightly different mix for this one. It looks like about 2/3 of you have said yes, you have a close working relationship, and about 1/3 of you do not. So in this next section, we're going to go through some of the specific types of opportunities that you may want to approach these local FQHCs to talk about partnering with them. And next slide. So this first slide is what I mentioned before, the spectrum of integration. And this is just a list of the different types of arrangements that we're going to go over today. So we've got referrals, co-located referrals, lease of personnel, transfer of sites, and corporate integration, better known as mergers. And as I mentioned before, we're not going to talk about subrecipient relationships again, but feel free to enter in questions if you have them. Now, none of these occur in a vacuum, and this list is certainly not exhaustive. There are many innovative ways for provider organizations to work together. It really depends on what works best for you and your community. So don't consider this to be the definitive end-all, be-all of possibilities for you to pursue. We'll move on to the next slide. We're going to jump right into the arrangements. And the first is a formal written referral. So under a referral arrangement, parties are seeking services from one another and agreeing to furnish services to the patients of the other party. So for example, a Ryan White provider might refer patients to a health center for a broader array of preventive or primary care services that they don't provide, or a health center might refer a patient to a nearby Ryan White provider for HIV testing and counseling, for example. In this type of collaboration, the providers remain responsible for the services that they provide directly and do not take on any responsibility for the other party. This is simply referring patients back and forth to two different providers at two different facilities, in all likelihood in two different locations. So we'll move on to the poll. We'd like to know what is your level of care coordination with a local FQHC? No FQHC in the community, no communication whatsoever, perhaps a limited cross-referral, but we offer primary care and then a full care coordination and referral process. We'll give you a minute to log in your responses. So it looks like about 65, so about 2/3 of you have a full care coordination and referral process in place. About 25% have a limited cross-referral 6% have absolutely no communication, and 3% have no FQHC in the community. So we're going to add one more question to go along with this poll. Do you have a written agreement with your local health center to cross-refer patients, assuming that you have an FQHC in your community and are working with them? Interesting. So we have about a 50-50 split. The no's just took a lead. So we've got 52% of you do not have a written referral arrangement, and 48% of you do. That's okay. So we're going to talk about how these formal referrals are arranged next. Okay. So if a health center is referring its patients to another provider, such as a Ryan White provider, for certain services in its defined scope of project, which, as you recall, we talked about in the first webinar, HRSA requires that they have a formal written referral agreement that includes certain provisions. Now, it doesn't have to be called a referral agreement. It can be called anything else, really, an MOU, it can be an MOA. All that really matters is what's in the agreement itself. So what HRSA mandates is pretty straightforward. You can see them on the 3 bullets listed here. The agreement must define the manner by which the referral will be made and managed. You must include a description of the process for tracking the referred patients and referring them back to the health center for appropriate follow-up care. And perhaps most importantly, third, the referred service must be available equally to all health center patients, regardless of ability to pay and in accordance with a sliding fee schedule. Now, we talked a little bit about sliding fee discounts in the first webinar, so if you need a reminder, be sure to check back and look at that. But here, keep in mind that the sliding fee scale for the referral does not need to mirror the health centers exactly. What's important is that at a minimum, it includes discounts for patients at or below 200% of the federal poverty level. Now, discounts can always extend above this threshold, but you must have those discounts below the 200% level. Now, for this webinar, you may have a scenario, for example, where a health center is referring patients to a Ryan White provider for specialized HIV services that are completely outside the health center's scope of project. And in that situation, these formal referral agreements, the written agreement that I'm describing with these required provisions here, are not required. So the health center you work with will know what's in or out of their scope of project. But if it's not in their scope, then you don't have to have these specific provisions. But we still recommend, of course, that you document whatever the relationship is that you have so that both parties are clear on the arrangement. Next slide, please. So as an alternative, very similar to but a more integrated form of a referral arrangement is a co-location relationship where 2 providers, perhaps already in close proximity or perhaps even sharing facility space, agree to work together. And oftentimes what we see is that one provider has excess facility space that they then lease to another provider. So they may have an extra floor or a couple exam rooms that they're not using, and they think that their patients could benefit from having a provider come in and use that space. So similar to a formal written referral, each provider in a co-location arrangement maintains its own practice and control. They agree to treat the patients referred to them, but this time the referral provider is physically in the other provider's facility. So for example, a health center might agree to provide certain medical services to patients of a Ryan White provider, but at the Ryan White provider's site. Or a Ryan White provider may furnish HIV-related services to health center patients at the health center site. So here you're improving the continuum of care and potentially reaching more individuals for these services. But there's no blending of operations, nor is there any exchange of funds between the 2 provider organizations, except, of course, if you are compensating for the space itself or perhaps certain equipment or supplies. And one really specific note here that applies to co-location arrangements, if you're entering into this type of relationship, please be sure to reach out to local counsel familiar with commercial real estate transactions and have them review any of the documents before moving forward. So let's talk a little bit more about the details here and move on to the next slide. Now, the title of this slide is a bit deceiving. It really should be general considerations, not just HRSA. Primarily when provider organizations enter into a co-location arrangement, it's important to distinguish between them. So, for example, signage indicating the health center's premises and differentiating an office or a group of offices that are used by the co-located provider. It could be brochures or signs indicating different office hours, or depending on the facility, even different entrances and waiting rooms. So pretend the second bullet is bolded and underlined. Be sure to review state law for additional requirements related to sharing clinical space. I cannot emphasize this enough. Some states have licensing laws that cover outpatient clinical sites where two separate providers are operating in the same space, and they might require that you have separate entrances or separate waiting rooms. And if it's anticipated that any given patient could see both providers in one day, there may be additional restrictions on billing for those services. So what is a HRSA consideration is this last set of bullet points. Just like the referral agreement, it's important to discuss and commit to paper in a formal written agreement the details of the arrangement. That includes how referrals will be coordinated, how billing will be handled, and any related lease of space or equipment. Particularly relevant here is the last bullet. The parties must consider how medical records will be shared to ensure that the process is compliant with HIPAA and any other state laws related to patient privacy and confidentiality. This is another one where state law piece should be bolded and underlined because many states have laws or regulations specific to HIV testing and treatment and how patient privacy concerns should be handled. Now, in these previous slides, when I spoke to the content of a referral agreement, the focus was on HRSA requirements and overarching state law considerations. So I'd be remiss if I didn't mention that there are, of course, other provisions that should be included in any of these agreements. Some of the standard provisions would be an assurance that providers have adequate malpractice coverage, either privately or through FTCA for the health center. You need to include causes for termination of the agreement, and a general assertion that the parties will not exchange remuneration for patient referrals. That was that anything of value that we talked about earlier. So, of course, you also need to ensure that patient freedom of choice and independent clinical judgment are preserved through these collaborative arrangements. All right, let's move on to the next slide. So as safety net providers move away from a siloed approach to care and toward integrated models, one of the most common collaborations that we're seeing between health centers and other providers is a lease of personnel. So here, one of the providers is procuring the clinical services of the other, but both entities remain separate and independent. For example, an arrangement we commonly see is that a health center's purchase of a behavioral health provider's time from a community mental health clinic. This often arises when a health center identifies a need for basic behavioral health services for its patients, and they want to provide it in a primary care setting, but they don't have the expertise in this area. So under this type of arrangement for a lease of personnel, the health center pays fair market value for a particular behavioral health provider's time to come to the health center and provide services to health center patients on behalf of the health center. So when I say on behalf of the health center is billing for these services furnished by the other provider and remains responsible for the services that the leased provider furnishes while under the health center's roof. So for example, the health center will be the one maintaining records for the individual, not the community mental health center. So in this situation, there may be circumstances where an individual requires more advanced behavioral health care, more than just the basic primary care that we were discussing earlier. And the health center would most likely refer that individual outside to the community health center that it's partnering with for more specialized care. Now, these are non-exclusive relationships, so there's no requirement to send that individual to the partnering community mental health center. It would simply be one of the options because, of course, patient freedom of choice and provider clinical judgment would dictate the ultimate choice here that was best for the patient. So you can follow a similar scenario with a Ryan White provider. And there are, of course, advantages and disadvantages to such an approach, But the core benefit to this model is that we're filling a gap in services and doing it in a manner that is truly integrated care, which is benefiting all the parties involved. So I want to reiterate one point that I made above. The behavioral health provider in my example is compensated for the time spent at the health center, but this compensation is not based on a proportion of the revenue that are received for the services delivered. Rather, the compensation is a pre-identified market rate in the community for those services provided by that type of professional. It's also important to keep in mind that FTCA would not extend to the contracted provider organization because FTCA only extends to individually contracted providers. So Nurse Jane, not Nurse Jane's employer, the Ryan White Part C grantee. And I want to make sure that that is clear. We're going to do one more poll in my section. So we'd like to get a sense of your experience. Do you currently lease providers to a health center? Looks like we've got most of the responses in, and we have the vast majority, so that 94% right now are saying no, you do not lease providers to a health center, and only about 6% said yes. So I want to ask about the opposite scenario too. Do you lease providers from a health center to your site? So this is the health center's providers coming over to you and providing services to your patients. We've got a little bit higher response on the yes answers here. About 17% say that you do lease providers from a health center, and 83% say no. All right. So that's good. We have some experience on both sides here. We'll move on to a few considerations for lease of personnel. So again, these aren't specifically HRSA considerations per se. These are general considerations, some of which we've talked about with previous models. So specifically for a lease of personnel, once again, to reiterate my point from the previous slide, although the leased personnel will not be receiving any revenue from billing the services that they're providing, the personnel will be paid a fair market value fee for furnishing services on the health center's behalf, and the agreement must show that this price is consistent with the community and is a fair market value rate. And again, as I mentioned before, because the services are provided on the health center's behalf, the health center is the one who's billing and collecting payments for the services provided by the leased personnel. And finally, the agreement must satisfy all of the federal procurement rules applicable to the arrangement, as well as any state restrictions as well. So let's move on to the next slide. One final key health center requirement relevant to this model is that the written agreement must specify that the health center has certain oversight and monitoring authority over any leased personnel, for example, cause for removal in certain circumstances. So when a leased person or a leased provider furnishes services on behalf of the health center, they're essentially becoming part of the health center's clinical team based on a defined schedule. They wear a health center name tag when they see health center patients. They are in the health center, and for all intents and purposes, they are temporarily health center employees. So as a result, the leased personnel must have qualifications that meet the health center's professional standards. That is, the clinician must be appropriately licensed, certified, credentialed, and/or privileged for whatever services it is that they're providing at the health center. And in addition, the leased personnel must abide by all the policies and procedures of the health center just as if they were an employee of the health center. So to protect the health center's interests, the agreement must also allow for termination or removal of specific leased personnel in the event that a particular individual fails to meet the professional standards, is not complying with health center policies and procedures, or just otherwise is providing care that doesn't meet the standards or expectations set by the health center for the services that they provide to their patients. And with that, I think I'm all set with my section. I'm going to pass the ball over to Carrie to talk a little bit about transferring clinical sites and different consolidation models.
Great. Thank you so much, Emily. Hello, everybody. I will do the last third of the training. Just as a summary, so basically thus far we've talked about options that don't result in organizational change. So the referral models, which is, there were kind of two prongs. The first was we remain in our existing locations, but we really improve the coordination of care by improving the communication related to how we're going to send patients from one party to the other, if indeed somebody at the health center is identified as requiring services provided by the Ryan White provider. That would be one direction. And the other direction would be if the Ryan White patients had a primary care need that is best served in a health center setting. So again, the organizations don't share staff. They're not sharing a facility space unless it's a co-location model, and there's no exchange of dollars between the two. The second model Emily talked about is the lease of personnel, which is where we do have some type of a procurement, a fair market value procurement for staff capacity to go to, let's say the health center. So from the Ryan White provider to the health center to see health center patients. The health center bills for those services, and the patients are considered health center patients, and the Ryan White provider would be compensated fair market value. So I just thought I'd just, before I delve on to the next one, just do a quick summary and also just make one point, and that is that the alternative, as Emily noted, of having the Ryan White provider be the purchaser, if you will, and having health center providers in its space, seeing its patients on its behalf, is indeed a totally permissible approach. And it sounds as though a number of you have that approach in place. But what is important to keep in mind is that when you have a Ryan White provider purchasing the services of health center personnel to see its patients on the Ryan White provider's behalf, FTCA does not extend to those health center providers. And the health center provider is billing, well, actually, it's the Ryan White provider is billing for services provided by the health center provider, but not in a manner that's based on kind of the health center's PPS rate, or as Emily mentioned, if you're in a state with an alternative payment methodology. So that's just a quick recap. What I'm going to talk about are a couple options that result in some type of organizational shift. So a much more consolidated approach. And I put them into three buckets. There's a little bit of overlap, as you'll see. The first is this transfer of clinical sites that I'll talk about. The second is a partial consolidation where we're having the transfer of some operations from one organization to the other, but not a complete merger. And then the third option is a complete merger, where you had two corporations at one point, two nonprofits, and at the end of the day, post-merger, you have one. So to kick it off, I'll talk about the transfer of a clinical site. This is particularly common with hospitals, and I recognize that a number of the Ryan White providers may be part of a larger corporate umbrella, part of a hospital system, if you will. And so, indeed, this may be relevant for some of you. But the common model is that a provider, and it doesn't, hospital is just one option, but it can be many other types of providers, identifies that it has an outpatient primary care location that it determines it's no longer really the best operator of that location. Clinical analysis is conducted, operational analysis, financial analysis, and it's determined that it would be better if the health center became the operator of that location. So it depends somewhat on your state, but essentially that provider, so it would be the Ryan White provider or the hospital, would cease being the operator of the location, and the health center would add that location to its scope of project. And a benefit of this transfer approach is that the patients who are served at this site that has become a health center site would be linked into the health center system. So they would have access to the health center's full scope of services, and it would expand the health center's operations. It would minimize the Ryan White provider's operations insofar as it ceases to operate that particular location. There are a couple key things to keep in mind. The first is listed under the caution, which is that the health center has to apply to the federal government before adding that site to its scope of project to say that it can, well, it has to make various representation, a key one being that it can operate the new site at a break-even budget. Another representation, it's not a representation you make to government, but another key requirement that's not listed here is that the intent behind this transfer cannot be that you have this site and it otherwise is remaining entirely unchanged. So kind of a turnkey scenario. One day, one organization is the operator, the next it's the health center, and the true intent behind this relationship is because we want to try to get those health center benefits, but we have no intention on really changing the services provided at that location. What you need is to have that site being transferred to the health center, being truly integrated within the health center system with the intent to expand operations, reach new patients, and, of course, see all of the individuals who present at the location for care, including uninsured and underinsured. Next slide, please. So again, this model is not as much a collaboration per se as it is a transfer. And the health center would be the autonomous operator of this location that the other organization would cease to operate. And there may be, however, some type of lease of facility space or lease of equipment, or perhaps even lease of personnel to operate this location. But again, the health center would be the operator. I am only describing thus far one direction from the Ryan White provider or its umbrella organization to the health center. You could have another arrangement where the health center transferred one of its sites out to the Ryan White provider, but you just don't see that very frequently, in part because once the site is added to a health center scope of project, it's somewhat hard to remove it. It may not make sense to remove it as it requires a federal approval, and in some instances the health center maybe receives federal grant dollars to operate that particular location within its scope of project. But it is indeed feasible, but there's no guarantee that would necessarily not result in a reduction in the health center's grant. And then there's, of course, the consideration that FTCA and the health center reimbursement methodology won't extend to a site that transfers from the health center to another organization. Next slide, please. So the next model is partial consolidation, and that is when essentially a line of business of one provider transfers from one organization to the other. One that I recently worked on is a somewhat large nonprofit organization that had a Title X line of business, if you will, and it ceased to get out of that area as its focus was really on housing. And the health center assumed the Title X operations, which means that there was a grant transfer of those Title X funds from this larger organization to the health center. The clinics that were family planning in nature were transferred to the health center, so the health center assumed the leases. And the personnel transferred, who were family planning personnel, transferred from the larger organization to the health center. I recall that some personnel were leased who weren't the clinical staff. I think there was some IT capacity that was needed, but there was a determination that it didn't really make sense to have them transfer to the health center's employment, so they remained with that larger organization. So as you'll see here, the health center assumed responsibility for operating that line of business. In this case, it was the family planning services. You could take the same approach with Ryan White, or it could be another line of business within your operations. The corporations remained separate, and they continued to provide autonomous services. And as I noted, there was some degree of leasing of assets between the entities as well as an employment transfer. Under a partial consolidation approach, the acquiring entity does not necessarily assume all of the transferring corporation's liabilities. So that is a benefit of a partial consolidation option. And how it is structured in the process for implementing a partial consolidation depends in large part on your state law. You will note here that I wrote parent subsidiary option provided that health center is the parent. The federal government, namely the Health Resources and Services Administration, has made it abundantly clear that it expects health centers to be autonomous operators, meaning that they aren't subsidiaries to a larger corporate entity. There is a concern that if you have kind of a parent corporation to a health center, that parent would exert certain authorities over the health center operations that conflict with those board authorities that Katie and Emily focused on during the last two presentations. So accordingly, when you're looking at these partial consolidation options, it's critical to consider that at the end of the day, the health center has to be an autonomous corporation. And that to the extent that you have some type of model where there is a parent, you will likely encounter challenges. So, for example, you may be part of an organization that is quite large, considerably larger than the health center, and it may make perfect financial and operational sense and clinical sense for the health center to become your subsidiary corporation. But because HRSA has in these various policies, there are the affiliations policies. If you're curious, it's 9727. They have stated that they are highly skeptical of parent subsidiary options. In practice, I have never seen one accomplished. I anticipate that some of you may be scratching your heads because you're aware that your local hospital has a health center as a part of it, or your local health department. That's probably because they fall within a bucket of some type of health center called a public entity health center. There is an exception to this kind of parent subsidiary concept if the grant recipient or the lookalike designee is a public entity. So, for an example, a local health department or a public hospital. Next slide, please. The last option is full consolidation, so some type of merger. An example would be that you have a Ryan White provider, the corporate entity, and you have the corporate entity of the FQHC combining and becoming one. The wording used that makes many people uneasy, but it is just the vocabulary of the transaction, is that you have a surviving corporation, and that is a corporation that continues in existence, and then the other corporation technically dissolves. So you don't have necessarily a new corporation in terms of corporate law. You have one of the corporations remaining that is a combination of the two. So one of the corporations technically dissolves. Now, the combined corporation, the quote-unquote surviving corporation, can have a new name. The parties can discuss ways to incorporate the dissolving corporation's policies and procedures. And there can otherwise just be initiatives to culturally have a new corporation that embodies the cultures of both, as opposed to that, dissolving, surviving corporation approach. And indeed, that's typically the case. When you look into a merger, it's very important that you do quite a bit of analysis ahead of time to really evaluate, do our cultures clash or do they combine? Where are the areas where our cultures and our approaches and our policies mismatch? And how do we address that? And can we address that sufficiently so this marriage makes sense? The surviving corporation, and now onto the second bullet, it takes title to all of the dissolving corporation's assets as well as its liabilities. So the financial analysis and the legal analysis in terms of outstanding liabilities is essential in whether or not to pursue a corporate merger. So again, we have this full consolidation where both organizations' lines of business blend together. You would have one board of directors. That's another area of complexity, is that you have to think about what that will look like, because presumably some individuals from the quote-unquote dissolving corporation who serve on the board will want to be a participant in the surviving corporation's board. Interestingly, I frequently hear of the merger approach in the context of having a CEO who's retiring, and perhaps he or she doesn't have a person lined up to fill his or her shoes, and or perhaps they think, this is a time for us to consolidate. We've been thinking about it for a long time. We know the other organization well, and this is a great time to pursue this shift. Next slide, please. Actually, while people are responding to the question, I'm going to keep babbling. So the question is, have you undergone or are you contemplating a merger with an FQHC? In terms of the benefit of a merger, and where I hear organizations say, this is something we've really been thinking about, we know it's a big deal, it's oftentimes driven by this conclusion that operating autonomously in the silos, despite all efforts to have an integrated referral relationship, release of personnel, that the duplication of services, and that doesn't necessarily mean clinical services, but duplication of all the administrative staff and the billing staff and IT, it's just so costly that sometimes these two organizations sit down at a table together and they do some analysis, a lot of analysis, and they come to the conclusion it is far more financially advantageous to combine operations. And they also determined that clinically, we can be perhaps not under the same roof, literally, but we can work together much more closely. We're all going to be employed by the same organization. There's going to be a lot greater communication about policies and protocols, and we'll be in one medical record system, and think of all the amazing things we can achieve. And then and we can reach more people, and we can do a better job at being a bigger safety net provider. So there are a lot of different reasons people approach it. So those are some of the pros. Some of the cons are that there's a degree of risk involved insofar as you don't entirely know the culture of the organization until you're married, the financial risks involved. It is not an easy transaction collaboration, but it is indeed increasingly common. So in terms of the poll question, it sounds as though 16% of you are saying you have considered or merging with a health center, or you have already undergone a merger. So that's interesting, and I'm sure a lot of that depends on your corporate structure, whether there are health centers in your community, and just frankly whether it makes sense. Next slide, please. Okay, I think I talked about this. Next slide. Okay, and there are various considerations that are specific to HRSA when we're talking about a merger that involves a health center. If you are looking to leverage the health center benefits, so that FTCA coverage, making sure that we can continue with PPS, reimbursement or alternative payment methodology, we're talking specifically Medicaid, of course, then the surviving corporation must be the designated FQHC. So you want to think about that calculation, that analysis when you are doing the analysis, because if you have a health center as a dissolving corporation, the grant does not transfer to the surviving corporation. Rather, the entity would lose its FQHC designation, and that has significant drawbacks. So some key considerations are service area overlap. You'd want to look at where your sites are, where the health center sites are, and would some kind of consolidation result in potentially new health center sites in the backyard of another health center that could object to the arrangement. The impact on the health center's scope of project. If the health center is adding new sites or services, it needs HRSA prior approval. I mentioned the potential change in CEO as well as the board composition. A key challenge, and now at the second class bullet, is this aligning project periods. I have found in my own experience working on these types of transactions that it can be very difficult for HHS, and specifically when we're talking about health centers for HRSA, to grapple with mergers where we have two different grants that don't have aligning project periods, just as a heads up. And then the last thing I want to talk about is the transfer of the grant, the successor and interest agreement. Next slide, please. The language in this slide comes directly from the HHS grants policy statement. So if you are contemplating a merger, I would recommend pulling out that document, looking for this language. I can't remember the exact page where it's located in the grants policy statement, but if you do a find for this language, it will pop up. You will see that HHS addresses the mergers by requiring that there is a successor and interest process. And basically why HHS has this defined process is that if you're having a merger that involves a health center, that involves a Ryan White provider, then that will impact the identified grantee under the arrangement. So if you are merging with a health center, ideally what you want is for that Ryan White grant to transfer to the surviving corporation, to transfer to the health center. Now, it's my understanding that if you had an arrangement where the health center was a dissolving corporation and the surviving corporation would be a non-health center like the Ryan White provider, that HRSA would require that the grant be recompeted. Rather than go into the stories of how this has been challenging, next slide, please. I'll just note that the key point is that you want to talk to your grants management officer before you go down this path, and the HHS operating division needs to be involved. It's not an easy process, and it takes quite a bit of time as well as the federal government's involved. Next slide, please. Skip this one. I think we've talked about this piece. Next slide. So the practical next steps are to identify the health centers in your community, become familiar with their scope of services, and inform them scope of services and your quality achievements. Because oftentimes it's impossible to know one another's operations, at least all of the great things you provide. And I find that oftentimes a great way to kick off the relationship is to keep it rather informal and to have coffee meetings to talk about trends you're seeing, services you provide, new grants you receive, new grants you're applying for, just to get to know one another. Because I think it's difficult to delve into any of these relationships if you don't have some degree of familiarity with one another. Next slide. So the predictable steps are outlined in this slide. I don't need to talk through them, but typically we see the relationship commence with a confidentiality agreement. So there's an understanding that to the extent we're sharing financial information, payer mix information, that will not be shared outside of the context of the discussions, and that there's some documentation as to what the prioritized initiatives are and the timelines to do the analysis without being too ambitious of things getting done too quickly. I always take the position that two individuals, the CEOs, for example, can't do this all themselves, so it's good to have some type of a steering committee that has finance and clinical and operations to answer some of the difficult questions that arise. Next slide. And then at the end of the day, you complete your due diligence review and you execute definitive agreements and you commence the process of obtaining the regulatory approvals. And throughout this process, you involve your respective boards to make sure that they are comfortable with the transaction, they are comfortable with the relationship, and this is, of course, particularly true when we're talking about the more consolidated approaches that I highlighted towards the end of the webinar. Next slide. So that is it. I know we have kind of one general question based on your experience working with health centers in your community, so I'll let you kick that off, and then I'll see if people have questions.
Great. Thank you so much, Carrie and Emily. Really terrific presentations. We did receive, Carrie, a couple questions that came in already. The first one is, are the leased personnel referred to in the agreement, are they referred to by name or by job description or position? So is it an individual or really the position that's being contracted?
I've seen both, and oftentimes it's identified in an exhibit to the agreement. You know, if we're talking about 5 different people or 5 different types of titles. But if we are specifically wanting Dr. Jones and she is the only one that we want to lease as under the contract, then I recommend naming Dr. Jones as opposed to just writing the words physician. It really depends on the transaction and what the desire of the purchasing entity is.
Okay, great, thank you. And then the last question that we received is you refer to the transfer of clinical sites to a health center But are you also talking about the transfer of a Ryan White provider location to a health center?
So it could be a Ryan White provider location. You just need to be very careful in terms of the implications, impact on your Ryan White grant. So that could be an option.
And this is one final question. It's a hard one, and it's one we've received before, and we're right at the top of the hour, but it's, can an FQHC legally deny primary care services, so not HIV care, but primary care services to a person, an individual living with HIV?
I think that question came up before during the first presentation, and I honestly didn't know on a federal level whether there was any prohibition, so I would recommend looking at state law. The answer may be yes. I don't know from a federal level.
Okay. And we can also follow up with HRSA to at least bring it to their attention. It sounds like it's something that has happened out in some communities.
It does sound like that, so we will work on getting some more information on that. But I think even if the answer is that there are no restrictions on the federal level, and I don't know that that's the case, there may be, that doesn't mean that there isn't something under state law.
That's a really important point. Well, we're just after 2, and I really want to just thank Carrie, Emily, and Catherine who participated on the earlier webinars for the terrific information. If anyone else has comments or questions, please feel free to submit them to us, and we'll do our best to answer them. But this will conclude our today's webinar and our series. So thank you very much.
Thanks.